Good afternoon, everyone. This is Dr. Praveen Pandey. I'm currently working as a senior resident at the Department of Psychiatry in MBBS, and we will be discussing obsessive-compulsive and related disorders, their identification and management in the present session. So, coming to the overview of this presentation, we will discuss all the disorders that come under the umbrella of obsessive-compulsive and related disorders, and it includes, but not limited to, obsessive-compulsive disorders, body dysmorphic disorders, hoarding disorders, trichotillomania, skin picking and excoriation disorder, substance or medication-induced obsessive-compulsive and related disorders, OCD due to another medical condition, and olfactory reference syndrome. However, the olfactory reference syndrome is not included as a part of OCRD in the DSM-5, but there are multiple overlaps in the symptomatology, so we will discuss it here today. So, what are obsessive-compulsive and related disorders? So, obsessive-compulsive and related disorders, they used to be formerly included under the umbrella of anxiety disorders, but this changed from DSM-5. In 2013, the DSM-5 included them under a common umbrella of OCRD. So, why is it so? Because all these disorders share clinical features, which is repetitive behaviors, comorbidity patterns, familiarity, neuropsychological deficits, treatment response, and importantly, shared brain circuit abnormalities. And along with that, hoarding disorders, which may not share many features with OCD, is also grouped along with OCD because of historical association with OCD and obsessive-compulsive personality disorder. So coming to the neurobiology of these disorders, there is a common neurobiology that is there in majority of these disorders, which involves the problems with the cortico-striato-thalamocortical circuit. So obsessions are linked to the cortico-striato-thalamocortical feedback loop from the prefrontal cortex, and overactivation of this circuit may lead to worry or obsessions. This is regulated by serotonin, gamma-aminobutyric acid, that is GABA, dopamine, norepinephrine, glutamate, and voltage-gated ion channels. In persons with OCD, the caudate nucleus is malfunctioning. The caudate nucleus acts as a processing center for filtering station for the messages generated by the frontal cortex. The caudate nucleus and the putamen, which together are called the striatum, take in messages from the cortex and function like an automatic transmission, assuring the smooth transition from one behavior to another. Typically, when anyone decides to make a movement, intruding movements and misdirected thoughts are filtered out automatically so that the desired movement can be performed rapidly and efficiently. There's a quick, smooth shifting of gears here. So what thoughts you want to carry on with, they go ahead, and rest of the thoughts are blocked. During a normal day, we make many rapid shifts of behavior smoothly and easily, and usually without thinking about them. It is the functioning of the caudate nucleus and the putamen that makes this possible. In OCD, the problem seems to be that the smooth, efficient filtering and the shifting of thoughts and behavior are disrupted by a glitch in the caudate nucleus. As a result of this malfunction, the front of the brain becomes overactive and uses excessive energy. It is like having your car stuck in a ditch. You spin and spin and spin your wheels, but without traction, you cannot get out of that ditch. With OCD, too much energy is being used in the frontal part of the brain called orbitofrontal cortex. The orbitofrontal cortex, which has an error detection circuit, becomes stuck in the gear. This is why OCD causes people to get a something is wrong feeling that won't go away. Now, some of you might know him. He is an American business tycoon, investor, record-setting pilot, engineer, film director, and philanthropist. And during his lifetime, he was known as the most influential and financially successful individuals in the world. Now, some may say that he's Tony Stark, but no, he's Howard Hughes. Along with all the great traits, he also had OCD. Some of you might have seen this movie called as The Aviator, where Howard Hughes is played by Leonardo DiCaprio. This is another such movie called As Good As It Gets. And this also portrays a very good picture of OCD, someone how troubling OCD can be in a person. And this person, many of you might know, this is Monica from Friends. She also had OCD symptoms. This is a famous TikTok star and currently an Instagram celebrity. She has started producing albums also. She also has OCD as well as tic disorder. So why do I show all these pictures to you? That anyone can have OCD, and despite having OCD, people can go on to live well-functioning lives if their symptoms are under control. And OCD is a syndrome characterized by presence of obsessions and compulsions. Now, what are obsessions? Obsessions are recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted. In most individuals, they cause marked anxiety or distress, and the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, that is by performing a compulsion. So I will reiterate this again. It can be a thought, it can be an urge, or it can be images which are recurrent and persistent at some point in the illness. It has to be intrusive and unwanted. And in most individuals, they will cause marked anxiety or distress. Now, compulsions, on the other hand, these are repetitive behaviors such as hand washing, ordering, checking, or mental acts. These can be behaviors and these can be mental acts as well, which can be praying, counting, repeated words silently that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress. They might be aimed at preventing some dreaded event or situation. And these are not connected in a realistic way with what they are assigned to neutralize or prevent. For example, if a person has an obsession that if he does not cross the door 3 times, something awful will happen to their parent, or an accident will happen to their dear one or near one. So they might count, like they might do it 3 times before they cross any door. They will do it 3 times. Now, this crossing door for 3 times is not actually going to prevent anything, because this does not come in a logical causation of events. But that person might have this belief that this will happen, and so they will keep on doing this. And this is not connected in a realistic way. Or they will be clearly excessive. For example, a person who is having an obsession that my hands are not clean, that if I use my hands to eat or touch anything, it will get contaminated. So they might wash their hands. And even after washing their hands for 3, 4, 5 times, and even for a few minutes to hours, they might not be satisfied that their hands are clean. So this is clearly excessive. Now, these repetitive behaviors, they are either not connected in a realistic way to what they are designed to prevent or neutralize, or they are clearly excessive. Now, for a diagnosis of OCD, as per the DSM-5, these obsessions or compulsions should be time consuming. That is, they should take more than 1 hour per day, or they should cause clinically significant distress or impairment in a social, occupational, or other important areas of functioning. They should not be attributable to the physiological effects of a substance, that is a drug of abuse, a medication, or another medical condition. The disturbance should not be better explained by another symptom of a mental disorder. So there are some differential diagnoses here to be considered. For example, in your previous classes, you might have learned that patients with depression may have depressive ruminations, but contrasting to the obsessions, they are usually egocentric, reflective of the depressive cognitions such as self-criticism, failure, regret, guilt, pessimism, and they are not going to be accompanied with any compulsions. In generalized anxiety disorders, there are anxious ruminations. These are about real life concern and they are not associated with any compulsions, rather more accompanied with avoidance. In body dysmorphic disorders, these concerns or preoccupations or obsessions are limited to physical appearance. In trichotillomania, these are limited to hair pulling. In skin picking disorder, confined to excessive skin picking. In hoarding disorder, difficulty in discarding or parting with possessions, accumulation of possessions, not secondary to obsessions. In eating disorders, these are confined to weight and food. If there are any preoccupations or repetitive behaviors, they are confined to weight and food. In tics, these preoccupations or behaviors, repetitive behaviors, are often preceded by premonitory sensations and not aimed at neutralizing obsessions. Additionally, in psychotic disorders, even with poor insight, if there is an OCD, these are all associated with typical obsessional content and compulsions, whereas delusions, which are in psychosis, they have persecutory, grandiose themes and symptoms such as hallucinations or formal thought disorders may be accompanying them. Additionally, there is something called as obsessive-compulsive personality disorder, and the difference here is that a personality disorder is an enduring and pervasive pattern of behaviors. In case of OCPD, there are excessive preoccupations with perfectionism, orderliness and rigid control, stubbornness, overconscientiousness, and typically these are egocentric, and there are no obsessions and compulsions. Now, if I tell you some common obsessions, commonest is contamination, then order or symmetry, safety, doubt of memory for events or perceptions, unwanted intrusive sexual or aggressive thoughts can be there, scrupulosity, that the need to do the right thing or fear of committing an error, breaking the law or religious transgression can be there. In case of compulsions, people may have checking behaviors, checking the doors, windows, electric sockets, appliances, safety of their children, cleaning or washing excessively, counting or repeating actions at a specific number of times, arranging objects in a specific way, touching or tapping objects, hoarding obsessions, confessing or constantly seeking reassurances, and continual list making can be there. When coming to the epidemiology of these disorders, mean age of onset for OCD is about 20 years, and 70% of cases with OCD, they will have their onset before the age of 25 years. So we can see that majority of these patients will have an onset in before the age of 25 years, and a larger part of their life, they will be facing these symptoms if not treated. And 15% of this population of OCD will be having their onset after 35 years age. Male and females have equal prevalence of this disorder. And in the general population, about 0.5 to 3% of people can have OCD. Now, etiology, if we talk about etiology, there are various explanations for this. We already discussed the neurochemical and neurobiological basis for OCD. There is also some immunological causation where cell-mediated autoimmune factors may be associated, such as against basal ganglia peptides, as in Sydenham's chorea. And in imaging studies, we have found that in CT and MRI, there is bilateral reduction in caudate site. We already discussed that the caudate nucleus is malfunctioning. On PET and SPECT scans, we have found hypermetabolism in orbitofrontal gyrus, basal ganglia, and cingulum that normalizes following successful treatment, either pharmacological or psychological. So it is reversible. Whatever brain changes are found in the pathological state, when once treated, they go back to normal. And in genetic studies, it has been suggested that 3 to 7% of first degree relatives are affected. Monozygotic twins, 50 to 80% may be affected, and dizygotic twins, 25% may be affected. And no candidate genes are as yet identified, but polymorphisms of 5-HT1B receptor have been replicated. This is a serotonin receptor. Now, psychological causation and psychoanalytical causation are also implicated in the etiology of OCD. Now, there are certain associations which are found with OCD: avoidant, dependent, histrionic traits, anancastic and obsessive-compulsive traits are found in many individuals prior to the onset of OCD. In schizophrenia, 5 to 45% may present with symptoms of OCD, and it is associated with a poorer prognosis as well. In cases of Sydenham's chorea, up to 70% of cases may have OCD symptoms, and there are other basal ganglia disorders also, such as Tourette syndrome and post-encephalitic Parkinsonism, which is also associated with OCD symptoms. Now, coming to comorbidity, there is various disorders which are comorbid with OCD. Most common of them is depressive disorder. Along with that, variety of anxiety disorders, eating disorder, impulse control disorder, and substance-related disorders may be comorbid with OCD. One thing important is that in cases of suicidal thoughts or behaviors, in case of depression, the risk of suicide is very high. Now, management plan, how do you go about managing a patient who you have diagnosed as OCD? First thing is you have to do a detailed assessment of symptoms and comorbid patterns, including suicidal behaviors, either by unstructured clinical interview alone or supplement it with structured assessments. Then you have to decide on the setting for treatment, whether you want to give outpatient treatment or you want to give inpatient treatment, depending on the severity and treatment response in past. Additional to that, you have to do detailed psychoeducation of the patient and family members about OCD, its course and treatment options, including the duration of treatment. Then you have to discuss with them the choice of treatment, whether they want to go with drugs or with CBT, that is cognitive behavior therapy, or with combination treatment. In the Indian context, since we do not have much of human resource for psychological interventions, we prefer medication treatment, which is SSRI. You also need to inform the patient and discuss the side effect of the drugs, which may happen after initiating the treatment, and discuss or have in place a follow-up plan after the treatment initiation. Now, there are some severity rating scales by which you can monitor the progress of symptoms, improvement or worsening. One of them is Yale-Brown Obsessive-Compulsive Scale. This has a symptom checklist and severity rating scale. There is also a dimensional variant. Just in the dimensional Y box, the various domains in which an obsession or a compulsion can occur are discussed, and it has to be evaluated. Now, patient education is very important, since majority of the OCD cases will be having a waxing waning course, more often a chronic course than an acute course. So it is very important that you educate your patient well regarding what obsessions and compulsions are, that OCD is a brain disorder. It is happening due to neurobiological changes, structural changes in the brain, and obsessions are not a reflection of one's character or unresolved mental conflicts, because some of the obsessions may be distressing to them, may be in opposite to their cultural beliefs. For example, a person who is having an obsession that he's having recurrent thoughts of abusing the god or goddess they pray, or they're having sexual thoughts or images with respect to their relatives, and they're not liking those thoughts, but still thoughts are coming to them. So they might have some shame associated with that, guilt associated with that. And you have to explain to them that this is happening to a brain disorder, and this is not a reflection of their character or unresolved mental conflicts. Then you have to explain the link between the components, that is obsession, compulsion, and distress. How the obsession arises, how it leads to the compulsion via distress. You have to clarify the myths and misconceptions that they may have about the illness. We have to discuss the course and outcome of OCD, that treatment may be prolonged. We have to provide information regarding the available treatment strategies and sensitize the patient with the idea that treatment is a continued process and often it may go long term. Now, which drugs will you give? See, SSRIs are the first line treatment for OCD. Majority of times, higher dosages are needed. These are the dosages enlisted here, which are commonly used in treatment of OCD. Then second line treatment, clomipramine and venlafaxine can be used if the first line treatment fails. But for adequate trial, at least 12 weeks of optimum dosage needs to be administered to the patient and followed up that he has regularly taken the medication. Then only you should move on to the next medication. If these all fail, if the second line treatment also fail, or there is a partial response, you may go on to use some augmentation strategies for partial responders, which may use antipsychotics, low dose antipsychotics, some buspirone or short-term clonazepam if there is excessive anxiety. And there are other adjunctive treatments, including mirtazapine, lamotrigine, and topiramate, which can be utilized in case of partial responders or treatment failures. Now, psychological treatment is also equally effective in treatment of OCD, but the thing is, in India, we do not find many clinical psychologists. There are less in number, so they might not be available. If available, it has to be offered along with the pharmacological treatment. Now, CBT is the mainstay here. It essentially takes a behavioral approach, including exposure and response prevention. Then behavioral therapy in form of response prevention useful in ritualistic behavior. Thought stopping may help in ruminations, and exposure techniques for obsessions may be employed. These are various kind of CBT. And psychotherapy in form of supportive psychotherapy is also valuable, including that of family members and using group psychotherapy. Now, CBT, what happens is CBT employs the dictum that neurobiological changes go on to produce behavioral changes. So if someone focuses on the behavioral change, that in turn leads to neurobiological change. So the brain pathology leads to behavioral pathology, and the change or the alternative approach to the behavior also goes on to reflect in the brain changes, and OCD is treated. Physical treatment, if we go on, so ECT can be electroconvulsive therapy, can be considered in cases who are suicidal or severely incapacitated, not commonly recommended for OCD. And psychosurgery, where you can go for stereotactic cingulotomy, is reserved for severe, incapacitating and intractable cases where they have treatment resistant and various treatment failures are there. Deep brain stimulation can also be used, but it is reserved for refractory cases only, severe refractory cases, and the efficacy yet to be established. Now, course and outcome, how a patient of OCD will usually fare in going forward. Often the OCD is having sudden onset after a stressful event, for example, loss, pregnancy, sexual abuse, and the presentation may be delayed by 5 to 10 years due to the stigma and secrecy associated with mental disorders. Symptom intensity may fluctuate or be chronic. Now, 20 to 30% of these patients with OCD, if treated adequately, will significantly improve. 40 to 50% will show moderate improvement with some symptoms which will persist but will not hinder with their day-to-day life or functioning. 20 to 40% of cases with OCD will have a chronic or worsening symptom course even on treatment. Relapse rates are high after stopping medication, so long-term treatment is recommended. Suicide rates are increased in this population, specifically if there is secondary depression. Now, coming to prognostic factors. There are some factors which are associated with poor prognosis and some factors which are associated with better prognosis. So poor prognostic factors are giving into compulsions, longer duration of symptoms, early onset, female gender, presence of tics, bizarre compulsions, hoarding, symmetry obsessions, comorbid depression, delusional beliefs or overvalued ideas, and personality disorders, especially schizotypal personality. Factors which are associated with the better prognosis include good premorbid social and occupational adjustment, a precipitating event that is which will have an acute onset, episodic symptoms, and less avoidance. How do you enhance treatment adherence? See, majority of the patient will have a chronic relapsing waxing waning symptoms course. So it is important that you emphasize on treatment adherence. And how you can do that is you can psychoeducate the patient and family members regarding the illness, prognosis, treatment. You have to provide education materials to patient and family members. You have to deal with their unrealistic expectations of quick recovery. You have to tell them that an optimum dosage for at least 12 weeks is to be given, and educate patients and family about lag in the onset of actions, and that improvement may occur over several months. For example, the SSRIs, they act at neurotransmitter level. So these take at least 2 to 3 weeks to start the action. And this lag phase has to be explained to the patient and patient's families. You have to sensitize the patient about potential side effects and help them to deal with them. You have to use medications that are effective, easily available, and affordable, and treat comorbid disorders and personality disorders, if any. If left untreated, this may contribute to poor treatment adherence. Now, this is Michael Jackson. Most of you will know him. And in the side, we are describing a patient who is having a body dysmorphic disorder. These are the persons which have preoccupation with the belief that some aspect of their physical appearance is markedly abnormal, unattractive, or pathological. This preoccupation causes distress and has the characteristic of an overvalued idea. It is not amenable to reassurance. The bodily part is found to be normal, or even if it is abnormal, it is only slightly so compared with the degree of distress. It is an unusual condition which has only relatively recently come prominently to clinical attention. It rarely presents directly, but such individuals may present requesting plastic surgery or mutilating surgical procedures and hence come to psychiatric attention. There are many similarities to OCD in terms of clinical features and treatment response, and it is now classified along with OCD. Now, clinical features may have preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to others. At some point during the course of the disorder, the individual has performed repetitive behaviors. For example, mirror checking, excessive grooming, skin picking, reassurance seeking, or mental acts. For example, comparing his or her appearance with that of others in response to the appearance concerns. Additional to that, the preoccupation causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The appearance preoccupation is not better explained by concerns with body fat or weight in an individual whose symptoms meet diagnostic criteria for an eating disorder. And any part of the body may be affected in these individuals, most usually the face, head, secondary sexual characteristics. The patients are majority of the times they will have preoccupations about the face, head, and secondary sexual characteristics. These patients believe that supposed deficit is noticeable to others and attempt to hide or minimize it. These beliefs may develop to a delusional intensity where they may not be amenable to reassurances. There is associated functional impairment and risk of suicide is also there. Then there may be some comorbid behaviors, for example, skin picking, rubbing, adding topical applications, which may worsen secondary problems. And this disorder causes severe functional impairment, as stated earlier, and there is risk of iatrogenic morbidity by unwarranted surgical procedures, because these patients are preoccupied with that something or the other is problematic with their body or their any organ characteristic, and they will insist the surgeons go on multiple visits and ask that they be treated for it. Now, coming to epidemiology of body dysmorphic disorder, equal sex incidences there, male and female equally affected, less than 1%, but markedly overrepresented in plastic surgery and dermatology clinics. 10% incidence in first degree family members, and 60% comorbidity with major depression. 60% of cases with body dysmorphic disorder will also be having depression. It begins in late childhood or early adolescence, and at this age when puberty is coming in the early adolescence, there are some normal worries associated with the body changes that are coming. Now it overlaps at this stage, but later on it goes on to continue and becomes worse in severity. Differential diagnosis, there is significant overlap in terms of symptom profile with social phobia, hypochondriasis, OCD, somatic delusions in schizophrenia, and anorexia nervosa. There may be some apparent overlap. Patient will present with similar characteristics, similar presentation, where they are not very comfortable with their physical appearance. They try to avoid going to social gatherings and try to have some repetitive behaviors which look like they have anorexia nervosa, but they do not. Now, coming to treatment, pharmacological treatment, as I told you, majority of these disorders share common pathology and common treatment responses as OCD. So here also there is some evidence for clinical effectiveness of SSRIs, preferably fluoxetine. You can start with 20 milligrams and increase up to 60 milligrams. And clomipramine can be tried up to 250 milligrams. For delusional features, if they are these somatic concerns or this preoccupation of these patients, these are all of delusional nature, you may add an antipsychotic. Psychological therapy is also very effective, and treatment is focused on response prevention, challenging the cognitive errors and behavioral tasks in the therapy. And operative plastic surgery to the affected part is not indicated at all, because even after surgeries, these patients may have these somatic preoccupation, these preoccupations with their body dysmorphia may return, and they may not get relief after the surgery and ask for surgeries again and again. For example, you have seen in the case of Michael Jackson, over the period of his life, he went on to have multiple surgeries in order to change his physical appearance, but the symptoms persisted. So prognosis wise, there is a chronic course with fluctuating symptom severity, and majority of the time there is a partial remission compared to a full remission. Now this is, as you can see, everything is scattered in all the places, and we also have Sheldon Cooper. If you have watched Big Bang Theory, you might know this character. He has hoarding disorder. Now, hoarding disorder is having persistent difficulties discarding or parting with possessions, regardless of their actual values. Even if the possession or the article that they are having is not having much of monetary value or emotional value, then also they will be difficult to discard or part with these possessions. And this leads to distress associated with discarding them, and it results in the accumulation of possessions that clutter active living areas. And there is significant impairment of social, occupational, and other areas of functioning. These are associated with or without excessive acquisition, and there is varying degree of insight regarding the symptoms. Coming to differential diagnosis of hoarding disorder, we have obsessions, we have depressive disorder, which has poor motivation. They may not be discarding stuff, and that is why they may be having a lot of stuff accumulated at their place. A person who has psychosis or delusions may have some disorganized behaviors. In autism, there may be some restricted interests, repetitive behaviors, which may look like hoarding disorder. A person with autism might be having some collection of specific items which are to his interest, and it may look like hoarding disorder. And in patients with cognitive deficits or dementia, brain injury, or cardiovascular diseases, and Prader-Willi syndrome also, similar symptoms can appear. And in older age, if this happens, some people also have called it Diogenes syndrome. Now, Diogenes was a person in Greek mythology and Greek history. So he was supposedly he was living in a jar, and people added his name to this disorder, but actually he was not having hoarding disorder. Now, coming to comorbidity of hoarding disorder, so 75% of patients who have hoarding disorder, they also have a mood or an anxiety disorder. At least 50% of these patients will also have comorbid depression, and at least 20% will have either OCD, social phobia, or GAD. Now, coming to epidemiology, the prevalence of this disorder is 2 to 6% in the US and Europe. Coming to Indian population, the prevalence is not well studied. More males than females in the general population are affected by hoarding disorder. While coming to clinics, females are more often diagnosed as having hoarding disorder compared to the males. And it is almost 3 times more prevalent in older adults, people who are aged 55 to 94 years, than younger adults who are aged 34 to 44 years. So majority of the patients who are having hoarding disorder will be older adults. That is what they call as Diogenes syndrome. And risk factors include indecisiveness in individuals with the disorder and first degree relatives, stressful or traumatic life events, and genetic studies suggest that 75% of variability in hoarding disorder is heritable. Coming to the course of hoarding disorder, symptoms may first emerge around ages of 11 to 15 years. They may start interfering with everyday functioning by mid-20s, and they may start causing clinically significant impairment and coming to clinical attention by mid-30s. It usually runs a chronic course. And coming to treatment, so as with all the OCRDs, CBT helps with decision making and coping skills. Individual, group, or family approaches have been used. Psychotherapy may be augmented with the trial of an SSRI. And we have to treat any comorbidity. For example, if depression or anxiety disorder is comorbid with hoarding disorder, we must manage those as well. Now, this is a photograph showing some snippets from people who have trichotillomania. The photograph in the right side is a trichobezoar, someone who started having trichotillomania, started ingesting their hairs, and these hairs, they do not digest and they accumulate in the gastrointestinal tract, giving rise to trichobezoars. Now, trichotillomania is recurrent pulling of one's own hair, exacerbated by stress or relaxation. The feelings of tension are relieved by pulling hair. It usually involves the scalp, but may also include eyelashes, eyebrows, axillary hairs, pubic hairs, and hairs from any other body region. Now, clinical features, there is recurrent pulling out of one's hair, resulting in noticeable hair loss, an increasing sense of tension immediately before pulling out the hair or when attempting to resist the behavior. So this is similar to an obsession. There may be pleasure, gratification, or relief when pulling out the hair. The disturbance is not better accounted for by another mental disorder. These are not due to any other general medical condition, for example, a dermatological condition which might be causing hair loss, itching, all these things. And clinically significant distress or impairment in social or occupational functioning is present owing to these behaviors. Now, associated features, there are some associated features in patients with trichotillomania, which may be there along with their hair pulling. They might also be engaging in examining the hair root, pulling the strands between teeth, trichophagia, they might be eating their hairs, nail biting, scratching, gnawing, and excoriation. Now, differential diagnosis for trichotillomania, we have to exclude OCD, psychotic disorders, Tourette syndrome, pervasive developmental disorders, stereotype behaviors, and body dysmorphic disorder. Coming to epidemiology of trichotillomania, in children, male and female are having equal prevalence, often with a limited course. They start and they may cease afterwards. And in adulthood, about twice as more as females will be there who will be having trichotillomania compared to males. And if it occurs in adulthood, if it starts in adulthood, it will have a chronic or episodic course. And lifetime prevalence of trichotillomania is 1 to 2%. Now, coming to comorbidity, trichotillomania may be comorbid with OCD, excoriation disorder, depressive disorder, generalized anxiety disorder, and personality disorders. Coming to treatment of trichotillomania, you have to treat any comorbid disorder that is existing with trichotillomania, any secondary medical complications such as any infection from hair pulling, all these behaviors, if it is there, you have to treat it. And CBT, behavioral modification, including substitution, positive and negative reinforcement is the key to treatment. And this psychological approach is most effective in cases of trichotillomania, one aspect of which is habit reversal training. Now, in habit reversal training, patients are taught to acknowledge and identify when these behaviors occur, when they are hair pulling, what are the triggers involved, how do they feel, what happens after that, what are the consequences. So they get to be more aware regarding the behavior that is happening, and then they substitute it with a competing response. For example, a person who is having an urge to pull their hair might make a fist and run it along their body. Similar kind of competing responses are the patients are trained in acting out these competing response, and over time with practice, the hair pulling activity is replaced by the competing response. Now, there is also evidence for use of SSRIs, clomipramine, pimozide, risperidone, and lithium. But majority of the patients will benefit better with the psychological therapy, and you can also augment with the SSRI. So excoriation or skin picking disorder, this has recurrent skin picking resulting in skin lesions, repeated attempts to decrease or stop behavior, significant distress or impairment of social, occupational, or other areas of functioning, not due to use of substance, not due to medical condition, not due to other mental disorder. So excoriation or skin picking disorder is similar kind behavior to the trichotillomania. Here also, females are more common going to have this illness, 3 times the male population, and 1 to 1.4% lifetime prevalence is there. It is more common in individuals with OCD and first degree relatives of patients with OCD. Now, coming to differential diagnosis, comorbidity, and treatment. The differential diagnosis, comorbidity, and treatment is same as for the trichotillomania. That is OCD, psychotic disorder, Tourette syndrome, autism, stereotype behaviors, and treatment also is similar, SSRIs and habit reversal training. Now, coming to the course of skin picking disorders, the usual onset is in adolescence. It may begin with the dermatological conditions such as acne. Sites of skin picking may vary over time. The course is majority of the times chronic and sometimes waxing and waning. Now, coming to substance or medication-induced obsessive-compulsive disorder. Now, there are various medications, treatments, and substance of use which may at times lead to obsessive-compulsive symptoms. Now, these patients will have, as discussed, like OCD symptoms, obsessions or compulsions, or trichotillomania-like behavior, or body dysmorphic disorder-like behaviors, or thought patterns, or patterns related to the skin picking or excoriation, but under the influence of a substance. either during substance intoxication or during withdrawal or after exposure to a certain drug. Now, we should also as assured that the substance which we are considering should be capable, should be known to produce the symptoms which are of obsessive compulsive nature, and it is a diagnosis of exclusion. And similar to all the other disorders we discussed, this disturbance causes clinically significant distress or impairment in the social, occupational, or other important areas of functioning. Now, coming to obsessive compulsive and related disorders due to another medical condition. So these disorders have symptoms characteristic of OCRD as described earlier. But in this situation, this disturbance is the direct pathophysiological consequence of another medical condition. So there will be some other medical condition, maybe some encephalopathy of some sort, some brain infection, some stroke, or other illness which is going to target or act on those brain areas which are responsible for production of these symptoms, and it will be preceding the symptoms of OCD or OCRD. Now, coming to olfactory reference disorder. Olfactory reference disorder is also known as dysmophobia and bromosis. It is also known as olfactory reference syndrome and characterized by the erroneous belief that one emits a foul or unpleasant body odor. There may be significant distress and impairment, including avoidance of social situations, repetitive behaviors, showering, use of excessive deodorants or perfumes, and level of insight may vary and sometimes may have a delusional quality. Now, coming to differential diagnosis, there may be actual physical conditions which may be letting the patient smell something arising from his own body. For example, in case of hyperhidrosis, halitosis, dental abscesses, rectal abscess or fistula, or in case of olfactory hallucination, which are arising from head injury, migraine, or temporal lobe epilepsy. The difference is in olfactory reference syndrome, it is a thought, a belief, in contrast to olfactory hallucination, which are sensory experiences. A patient with olfactory reference syndrome will say, I think something, I smell something, I think I smell something, but I'm not actually smelling something. But a patient with olfactory hallucinations will say, I'm actually smelling these bad smells. Now, there can be psychiatric conditions which may present similar, which may have similar outward presentation to olfactory reference syndrome, including social anxiety disorder, OCD, body dysmorphic disorder, delusional disorder, schizophrenia, schizoaffective disorder, and avoidant personality disorder. There is also a culture-bound variant called as Jikoshu Kyofu in Japan, where the person has very strong belief that he's emitting some bad body odor. Comorbid conditions may include depression, which may be secondary and severe, social anxiety, OCD, body dysmorphic disorder owing to these symptoms. And prevalence is about 0.5 to 2%, but may be higher as these cases are underreported. Course may usually onset is in mid-20s, but can present earlier also. It runs a chronic course usually, and up to 2/3 patients similar to OCD may respond to treatment. Now, what treatment can be used for olfactory reference syndrome? Combined approach is best, like for all the OCRDs, if it is available, psychological as well as pharmacological treatment should be used. And you should, like in all OCRDs we have discussed so far, you should actively treat any comorbidity. And pharmacological treatment, there are no actual RCTs, no randomized controlled trials which support the use of SSRIs. But there are case reports where patients have responded to the SSRIs or antipsychotics, either alone or in combined. And psychological also, CBT has been used, but there is no strong evidence. So these are the references for today's session. You can look at these books and articles to get a broader view of obsessive compulsive and related disorders. And thanks for your patient listening. You can find a recorded video of the session on YouTube on Telemedicine Enhanced channel. Please subscribe and enable notification. For any query regarding today's topic, you can mail me at parvinva@gmail.com. And you can access this presentation at the link that will be provided in the YouTube video description. Thank you, everyone.